All right, ladies and gentlemen, thank you all very much for joining us today. This is the regularly scheduled meeting of our Health and Hospital Committee for the County of Santa Clara. First item of business, of course, is to call the meeting to order, and we do that by establishing the presence of a quorum. So we will ask the clerk to please call the roll. We shouldn't take too long with two established committee members.
Vice Chairperson Lee
Good afternoon, President.
and Chairperson Simonian.
Here.
We have a quorum, thank
And if
you.
you can speak up a little bit, that would be helpful. And call to order is complete, and presence of a quorum has been established. That takes us to public comment. Public comment, of course, is that portion of our agenda set aside for comment by members of the public on non-agendized items that are properly within the jurisdiction of this committee. Let me turn to the clerk and see if we have any cards for public comment or speakers online.
We do have a request to speak in the room.
Great. Would you hand that to me so I can call that speaker up? And pursuant to the rules of the board, we will set aside up to 3 minutes for such speakers. And I see we have Mr. Paul Soto with us. Mr. Soto, please feel free to come forward.
Good afternoon. My name is Paul Soto from the Horseshoe. I wrote this while I was, the last term that I had in prison, I wrote this. Violence, be it economic, physical, or psychic, manifests in many ways. I live in a managerial society in a world of admins. The greatest acts of violence is not now done in the sordid dens of crime that Dostoevsky loved to paint. It is not done even in the concentration camps, psych wards, or prisons. In these, we see its final results. But it is conceived and ordered, moved, seconded, carried, and minuted in clean carpeted, warmed, and well-lit offices by quiet men with white collars and cut fingernails and smooth-shaven cheeks who do not need to raise their voice. Hence, naturally enough, my symbol for hell is something like the bureaucracy of a police state or the offices of county and city government buildings. It was in offices like these, with men dressed like this, that conceived children to work under crippling work with short-handled hoes in the agricultural fields of San Jose, California, and other parts of the state. The sight of returning children with spines permanently bent from such work remained all too common throughout the 1940s and 60s. Was this violent to do this to both my mother and myself? Am I not confronted daily with the reality that the United States government, County of Santa Clara, City of San Jose deprived me of something private that I had a constitutionally protected right to possess? Language. Is this not violence towards the tens of thousands of Chicanos who grew up not speaking Spanish? Where is my just compensation for taking something as fundamental as language from the Chicano? San Jose redlined the Mexican, stripping him of ancestral wealth. Chicanos of my generation were burglarized, robbed, using force of law in fear of the policeman's club. From wealth we normally would have inherited had the Chicanos' right to private property been respected. Does not the Chicanos of my generation deserve equal protection under the law and due process as we redress the historical injustices? San Jose stole from Chicanos the security and stability in these uncertain times of gentrification and cultural paradigm shifts that are heavily promoted by Scott Neese, Gary Dillabo, Jay Paul, Eric Hayden, and Alex Shore. In conclusion, it is my contention that the greatest acts of violence in San Jose, Santa Clara County has done to los campesinos de Sal Si Puedes y los Chicanos de Barrio Horseshoe is to deny us our humanity. And you deny us our humanity when you deny us our history. Now, you talked a lot about in today's agenda, well, when we get to that point, about racial equity. Now, if it doesn't include anything in here, save your rhetoric about racial equity, because you know nothing about it. You were never raised in Barrio D11. I was. D11 was the lowest designation on that redlining map. So before you start talking about equity, you need to start asking some serious questions first. Thank you.
Let me check with the clerk, see if that is our only speaker, or do we have any others under public comment today?
There are no requests in the room and there are no requests online.
All right, then that will take us to item number 3, which is to approve the consent calendar and changes to the committee agenda. Supervisor Lee, just a little bit of a wrinkle here that I'm going to try and address. We have items 8, 9, 10, and 11 scheduled for consent. All good with that. If you have any item that you think should be removed, you will, of course, let us know. But I also want to ask, because I understand that Mr. Williams is not with us this afternoon, and Ms. Hanson is with us, but only until 4, that we bring forward the report in item 7F. Ms. Lowther, that's your area, because I want to try and coordinate information on this subject with your offices, but also with the county executive and the county's chief operating officer. If I could get a motion to that effect, I would bring that item forward first so that we can make sure we take that item up even before we get to the public health officer and COVID-19.
So moved.
Motion by Lee, second by Semidian. Do we have anyone who would like to speak on item number 3, which is to approve the consent calendar and changes to the committee agenda?
There are no requests to speak for the consent calendar.
Call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Smidian.
Aye.
Motion
Thank you
carries.
very much. That motion passes, and please note, that means we will move immediately to item 7F. And Ms. Lowther, sorry to put you on the spot with no notice, but only just discovered that we wouldn't have the full complement of staff support. So if you could go ahead and tell us what's the latest in terms of our ambulance and our dispatch, and I know we've had some inquiries from the media, and I wanted to get a handle on where things stood. This is something we've talked about at prior meetings, so where are we and what are our plans for the future? I guess what I'm really trying to do is figure out what we're doing and when we'll know if it's working.
Good afternoon, Supervisor Semidian and Supervisor Lee. Currently, for our reconciliation, we're at 2,336 yet to be reconciled from our last meeting. And with our new CAD, which went live on September 12th, they are currently, First Watch is still in the midst of loading all of those into the system. And of those, there's 2,371 of those that need to be loaded. The anticipated reconciliation for the January through August, as requested by yourself, should be done by the end of October, so that we should have some data for you prepared for the November meeting. For the new CAD system, they're having some difficulty because the AVL, which actually tracks the route of the ambulance, has not been loaded for AMR. And until that occurs, AMR is having some difficulty in checking on their own reconciliation. First Watch anticipates that all of that will take probably until the end of October, early November. So hopefully by our November meeting, we'll have a better sense of where we're at. Because of the difficulty with the dispatch go live, the CAD go live, wasn't dispatch, there were some late calls around the 12th, that first week, getting used to the system.
Could you pull the microphone a little bit closer, please? And I'm particularly interested in the implications for all this for the standard dispatch order number 17, which, as I understand it, is the order that's issued when we have a system that is unable to respond in a timely fashion.
Yes, sir.
And my further understanding, and thank you for the information, I keep saying my further understanding, but thanks to you, I understand that this year alone, I think we've had 145 of these. So what does that mean in terms of keeping people healthy and safe, in terms of when they call the ambulance is supposed to get there?
So every day we have a deployment methodology that was based on the number of calls anticipated for that particular day. Whenever those levels of number of ambulances drops to level 0, that means 0 ambulances throughout the county, that's north, south, east, and west, to 0, the duty chief, which is our 24/7, 365 person who's monitoring the system, will enact SDO 17, which basically means, tells the dispatchers, do not send an ambulance until the first responder, which is fire, gets to the scene and determines there is a patient. And what I mean by that is sometimes a police officer or someone might call and say, there's 2 individuals fighting, there may or may not be a patient. I see someone lying on a street corner, they may be asleep, there's not a patient. So we verify that there is a patient in order to keep that resource in the system. When those levels get back up to 8 ambulances throughout the county, we take and turn off SDO 17. And throughout, since January of 2022, we've had 145 of those particular SDO 17 instances.
Forgive me, thank you. I'm not sure if I misspoke earlier or referenced the correct date and time, but that would mean over the course of a year and 8 months or a year and 9 months, we've had 145 of these events. Is that a lot or a little compared to our history over the course of, say, the last 5-10 years?
Over the last year, since February of 22, we have had multiple instances of SDO 10 and 11, which SDO 10 and 11 is when we allow fire departments into the system to assist. There have been many, many, and I'd have to get the numbers for you on that. So relatively speaking to our deployment numbers over the last 18 months, I would say that is relatively low.
All right. Ms. Hanson, I want to ask you to weigh in here. Ms. Lowther, correct me if my memory fails me, but my recollection is that we had some late arrivals on the part of our contractor, Rural Metro AMR. We identified part of the reason for that being simply a staffing challenge. We took some steps to see if we could help increase the number of folks available for these jobs. We were cautiously optimistic that that was generating some benefit. In addition to those late arrivals, however, then we had the database problem. And in addition to the database problem, we now have the, I'm going to call it the SDO problem of simply not having enough ambulances out there. At this point, I'm sort of like 1, 2, 3, where are we? And, what are we going to do to make sure that we can confidently say to people, you dial 911 and you need an emergency responder and you need a paramedic and you need an ambulance, they're going to be there on a timely basis. So, Ms. Hanson, I feel like this conversation's sort of been underway for too long. And what do we need to do to actually wrestle this one to the ground and get some results? Because candidly, when I first came on the board, the problem was with San Jose Fire and their inability to get to their calls on a timely basis. It took quite a bit of time and effort and some financial penalties to finally wrestle that one to the ground. But I'm no more prepared to say this is acceptable than I was with the city of San Jose when the problem was in their shop.
I can speak a bit to that, and what I would say is consistent with what Jackie was mentioning related to the persistent staffing challenges that AMR and other ambulance providers are having. We're dealing with, in the emergency medical response realm, some of the same profound staffing challenges post-COVID that we're seeing in other parts of healthcare delivery, which is going to require us to do some reassessment of the way that we structure our system. And we, as you know, are on the cusp of looking at rebidding. So that will allow us to revisit some of the contracting structures related to how we deploy ambulance services and ensure robust coverage. But I think we're also going to have to look at all the places where ambulances are being used where they're not needed. And so Jackie mentioned there are instances where under SDO 17, we are leveraging the fire emergency medical response to allow ambulances not to respond to instances where there is no patient for them to treat. We're also seeing significant opportunities to make sure that we deploy other transportation to medical care than an ambulance, where right now ambulances are, for example, being called because there isn't another way for a person to be transported to urgent care, say from a homeless shelter, where a person may need some support to see a provider, and because there's not another means through which that person can get transported. So we're looking at lots of opportunities like that to make sure that our ambulance scarce resources are deployed only where and then available to timely respond to where we have need for ambulance level response. And I know there's also work being done, and as was referenced in some of the communications the board's recently received, work to make sure that our ambulance offload times at hospitals can improve. And I know Mr. Lorenz might be able to speak to some of the work that's happening in our health system to make sure that we can also get ambulances back out to be responding to more calls, because that's another opportunity that we have to increase the capacity of the system to ensure that we have really robust and timely ambulance response to all calls where an ambulance is needed.
All of that notwithstanding, this is a conversation that's been going on for too long. Let me ask the question, County Council is represented today by whom?
Michaela Lewis, Assistant County Counsel.
And I wonder if I could ask you, does this mean AMR is out of contract?
I would have to look at the specifics of the contract. I don't have that at the top of my head, but we can
Need
do
you to
that.
talk right into that microphone, particularly with
course.
the mask. Thank you.
I need to look at the specifics of the contract. I don't have that information off the top of my head. My apologies.
No, I understand, and I also understand that open session may be challenging, but I also feel like we've been talking about this in open session for several months now, and the issue is not only not resolved, in some respects, Ms. Lowther, I think it's actually gotten more challenging. You know, at one point, we were talking about a limited number of late arrivals. That was disconcerting. Then we got to the point where we were talking about the fact that we weren't really able to be confident in our assessment of the arrival times because of the data problems. And now we've also got the challenge of the dispatch orders. And Ms. Hanson, I take your point that at a difficult time like this, we need to be making sure that we send don't send scarce ambulance resources to places where they aren't really needed. But we had a set of standards in place. We have a set of standards in place. And presumably we negotiated those because we thought they were realistic and reasonable, and they're not being met. So I'm going to ask administration, including Ms. Lowther's office, but also the county executive and the county's chief operating officer and the county council, to come back with a plan of remediation at our next health and hospital meeting. And I don't usually like to do this, but if that doesn't happen, then and folks are out of contract, and I'm going to ask for an off-agenda confidential memo on that issue to county council's office, then I'll start to bring motions to take whatever legal action is necessary, because I can't sit here meeting after meeting with assurances that it's going to get better to discover that we haven't found a way to solve the problem. I get that it's hard. I get that there's a labor shortage. Here's what I get. I get that there has to be a solution, and I'm looking for a real solution and a plan of action that's going to solve the problem on all three fronts. And if that means somebody has to get up and go to work and stay at their computer screen until the data issues get resolved, then so be it. You know, if folks are puttering along at, a level that isn't solving the problem on a timely basis, that's putting people at risk. That's not acceptable. So I don't want to press this point too much, but enough. Let's go. Hustle. It's time. It's long past time. And if I seem grumpy about it, it's because I'm grumpy about it. And I'm grumpy about it because real lives are at risk in every part of the county. Not acceptable. Okay. Okay.
Understood.
I'm going to ask for a second to a motion on this item, which is that we will direct staff to come back with a plan of action at our next Health and Hospital meeting in November, and direct County Council to deliver an off-agenda memo on whether or not AMR is in contract. And before AMR starts sending off emails and picking up the phone and calling, I'm not interested in taking meetings to have a further conversation. I'm interested in hearing what the solution to the problem is, okay? And that's not to point the finger of blame that way, or that way. It's just to say it's time. That's my motion. Can I get a second? Thank you. I got a second. Do we have anybody who wants to speak specifically on this item?
There are no requests to speak.
Say again?
No requests to speak.
Thank you. Please call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simonian.
Aye.
Motion carries.
Motion carries unanimously. Thank you. Ms. Lowther, the good news for you is you're good for the day. So thank you for staying with us, but we will not need to come to your item, which is 7F, I believe, when the time comes to take the director's report. All right, then, that takes us back to our regular order, and that is a report from the Public Health Officer relating to COVID-19.
Thank you so much, Mr. Chairperson, Mr. Vice Chair. Dr. Sarah Redmond for the Public Health Department. And just a few brief items today. First, an update on where we are headed into the winter respiratory virus season, as well as a few items about how the Public Health Department is thinking about our work overall going forward. There we go. So as always, I start with our wastewater, which is the best indicator of how we're doing with respect to COVID. I'll say that this screenshot was taken yesterday when all of our county sewer sheds were below the high medium threshold into medium. We have had one creep back into high as of this morning. In general, we've been hovering around the lower end of high and the upper end of medium across the entire county for some time. But the overall late summer surge appears to be waning somewhat, leaving us in a good position to go out and get boosted and send ourselves into the winter as protected from COVID as we can be. In addition, last week, the County Public Health Department went live with a new website that helps residents look up the same information for RSV and flu, the two other winter viruses that are most likely to have significant disease and potentially deadly consequences for vulnerable community members. And you'll see here the peaks on the left side of these two graphs, on the top for flu and bottom for RSV, show those winter surges we had last year and how different things look in winter versus summer for these viruses. And then little blips starting at the end of last month, beginning of this month for both diseases, which may impede the coming flu season or winter virus season for both diseases. And then finally, a brief COVID vaccine update. Just to let folks know that we are up and running all over the county with access to the new COVID vaccine. The system the Public Health Department has access to tell us how many shots were given as of 2 days ago showed over nearly 75,000 shots, but sometimes there's a lag, so we anticipate that number is actually higher. In addition, last week, the FDA authorized an updated version of Novavax, although that's not yet available in terms of supply reaching the county. But for folks who, for whatever reason, cannot safely receive the mRNA vaccines, the Pfizer and Moderna vaccines, this offers a third option for them. And then I have been able to confirm that all of the major county healthcare providers, in addition to all of the retail pharmacies, have received at least some supply of their COVID vaccine and are up and running to some extent this week. And because I mentioned to you 2 weeks ago when we gathered that we were holding back on a more aggressive push to make sure folks understood that it was time to go out and get vaccines, I want to let you know that we are no longer holding back. We are going out with both traditional media and social media to make sure folks in every language have access to information about the fact that it's time to go get your updated flu and COVID shot and where to do so. And then just a brief item on what the Public Health Department is thinking in terms of our overall focus and priorities as we look towards the end of this year and the beginning of next one. Late this summer, we published our updated strategic plan that is really designed to take many of the lessons I shared with this body in the spring that were learned during the pandemic and focus on how we do our work as we face a number of different content areas that may evolve, whether that be climate change or substance use or violence prevention. The how of doing so with a public health lens and leveraging the amazing systems and partners we have across the county is something we wanted to make sure is clear to the public and available to them so they understand where we work and how and why we do it. The why is ultimately to make sure that everyone in our county has access to the ability to thrive in healthy and safe communities. And the details of the full strategic plan can be accessed with this QR code. But the focus is areas on on how we do the work we do really falls into these 5 areas. And I hope that's clear in these various reports you hear from me, that ultimately our goal is to constantly be looking to close racial and health equity gaps, to understand who's most negatively impacted by any given health concern, and then focus our resources and our work to combat those inequities. And we do so by thinking about how we can change policy, how we can form partnerships that elevate the voices of impacted communities and work closely with them to design the solutions that will work for them, how we can do so using modern technology and data, and how we can make sure that we have built and sustained the public health workforce that's going to be able to do this work well every day and into the future. That's the end of my presentation for you, and happy to take any questions today. Thank you.
Thank you. Before we go to questions, we do have one speaker. That's Mr. Paul Soto. Mr. Soto, you have up to 2 minutes. Please come forward if you like.
Paul Soto from the Horseshoe, thank you for that report. You highlighted, and I was very impressed by it and pleased by it, that you, at least rhetorically, were able to center racial equity in the issues that impact certain barrios, and it has been impacting over decades. So a large portion of the Chicano movement that was spearheaded by Confederación de la Raza Unida and United People Arriba was healthcare. That was one of the primary. And so we don't need any more data. Well, come on, we don't need that information. We're still 50 years later, still needing to have a talking session about what it is that we need to do to institute something that was addressed as an issue 50 years ago. I mean, that's pretty disgusting. And yes, Mr. Lawrence, I mean, people are dying because you're in control. People are literally dying and you're comfortable with it. That makes me very uncomfortable as a human being to know how comfortable you are with your failures. Because what it means is people are dying because of your inadequacies and your incompetency to deal with this issue. You see, policy is being instituted in this county because of my advocacy. I don't get paid a dime. You get paid hundreds of thousands of dollars. I don't get a penny. No, you know what I got? I got a $100 Target card. That's what I got. And my policy issues that I raised are inside these documents. Where are yours? I'm providing solutions. You're providing status quo, and I'm sick of it. People are literally dying because you were in a position. You play as Semidian's lapdog, and it's killing people. But you'll give a De Anza College a clinic. That doesn't look like racial equity to me, and it doesn't look like it to it in my community either.
Let me just check with the clerk, see if we have any other speakers on this item.
There are no requests to speak.
All right, Supervisor Otto Lee.
Thank you very much, Dr. Redmond. During the first week of the distribution of the new monovalent vaccine for the COVID vaccine, there were some shortages. Has that shortage been resolved at this point, or is it still working through the system?
Our best understanding as we're able to track is that the major providers whom we've been in contact with have received some of their supply. In particular, in terms of ongoing delays, though, I do understand that some of the pediatric supply is arriving later than originally recommended. I would defer to my colleagues on how that may be impacting county-delivered services, but in our attempt to help make sure other non-county service providers are at least keeping us up to date in what folks should expect, we're hearing significant delays in receiving their pediatric supply and therefore slower than hoped for rollout in access to pediatric boosters. That said, I do hear that most of those service sectors, those service providers have some pediatric vaccine availability, some appointments available. And I would say, I think I'm thrilled to hear the interest that folks are expressing in going out and getting vaccinated as soon as possible. But I'm also very comfortable with folks getting it next week or the week after, as long as we're really making sure that folks head into the holidays protected.
Okay. The other issue that I've been hearing, which is something completely new to me, is regarding funding, and that how those who are not insured might have to pay for the vaccines. Would you please educate me how we can get this issue resolved? And does that also mean that we no longer have this no wrong door approach on getting COVID vaccines?
What we have this year is a return to the systems that we've relied on for other vaccines prior to the pandemic, and I think highlighting, therefore, some of the gaps that those service sectors provide. When it comes to COVID vaccine, however, there is a specific program that is meant to ensure that people who do not have insurance still have access to free vaccine. And that program is called the Bridge Access Program. And for adults over age 18, which can be accessed by going to vaccines.gov and looking for the nearest site. Those sites can include doctor's offices, county services, but also retail pharmacies. And nearly every single Walgreens and CVS in the county is enrolled in that Bridge Access Program to ensure that uninsured adults can reach it that way. For children, it's a bit more complicated. They must go through the Vaccines for Children program, a federal program that works with many, if not almost all, of our major pediatric providers in the county. And that, again, is narrowing that previous expectation that folks can go absolutely anywhere and expect to receive a free vaccine. There is now a different door for different folks depending on their insurance status and age, but there are doors open all over the county.
Just from listening to you, I feel that this is going to be a massive undertaking to try to get the messaging out. It is not going to be easily understood, even those who speak English, and you have to translate into in language to the public. How are we making sure that people understand what they need to do?
An excellent question. I think ensuring that people have access to this now much more complex information in a language they understand is a top priority for public health. We've started by working closely with multiple news agencies that are connected with different communities and provide news in language, explaining how to access the different sites that direct somebody to the right kind of provider for them based on their insurance status and age. In addition, our social media campaigns are also offered in Spanish and Vietnamese, as well as our websites that help direct people to the right place to go.
Okay, we have a website that we've used for a couple of years or 3 years now, that's ccfreevax.com. .org? .org, okay. If somebody goes into that site and try to get an appointment with, say, a pharmacy or clinic, during the enrollment process, they will have to provide the insurance information before appointments made. Is that correct?
It's correct that that process is no longer as streamlined as it used to be. All of these sites that help people find the right provider based on insurance status, age, and location direct people to sites owned by Walgreens, CVS, a particular healthcare provider, and go through enrollment or scheduling process based on those individual groups. And so whether that insurance status is collected up front or at the time of arriving for the appointment may differ based on who's providing the vaccine. And that may lead to some of the surprises people unfortunately encounter if they show up somewhere and have not yet had an opportunity to double check that their particular insurance is accepted at that location.
So based on what you told me, it sounds like there will be folks who make the appointment, show up to the site, and will be denied the vaccine because they don't have the proper paperwork.
It's very unlikely somebody would be denied vaccine, but they could be asked to pay out of pocket up front and then seek reimbursement, which we know is a barrier too high for many of our community members to overcome. So that's why we're focusing on making sure people understand where to go to first time around so that they're headed to the right place that we know can serve them at no cost to them.
Okay, so now let's talk about the cost. If they paid out of pocket, I was told there's a different price if they pay before the shot versus after the shot. Could you explain to me why there's a difference?
I don't have details on that. I don't know if any of my colleagues might, but otherwise I can get back to you with more information.
Paul, do you have something about that?
Supervisor Lee, I'm not aware of different prices within any particular system
Okay.
in terms of self-pay. But it could vary from system to system because the vaccine is one part of the cost, and then you have the administration fee as another part of the cost.
So what is the quote-unquote going rate, or are they fixed throughout the system, or some pharmacy charges more and less?
I'd have to get back to you in terms of what our specific rate is, but I believe it is different based on the administration fee if they so choose to charge it.
And of course, our system, our clinic also provides vaccines. And so if folks comes to our system and they are not eligible based on these programs, how much would they have to get out of the pocket in order to get a vaccine?
So let me just walk through the process
Please.
in our system. So an individual makes an appointment,
Yes.
arrives at our location. We will collect any insurance information that they may, if they in fact have coverage. We will provide the vaccine and bill the insurance company. If an individual is not covered by any insurance carrier, we will ensure that that patient goes through our financial eligibility process, and if they meet the criteria, then that fee will be waived based on their income eligibility. And that is our process relative to ensuring that individuals receive the vaccine based on their ability to pay.
Right. When you say insuring their insurance company, from what I've learned, and correct me if I'm wrong, systems like Kaiser is different. Like Kaiser generally do not want you to go outside the system to get their vaccine. So let's say a Kaiser patient show up to a clinic, wants to get a vaccine, what would happen to them?
We will, first of all, bill Kaiser directly.
So we'll take their Kaiser membership information.
Yes, we will.
Okay.
One of the things that we do up front is advise and encourage people to go to the provider regarding their vaccine. We have heard, for example, Kaiser is not allowing their members to go to a CVS or Rite Aid, and they're directing patients to go to their normal provider that they would otherwise be seen by within the Kaiser system. So it is difficult, as Dr. Rudman has said, depending on your payer, your insurance coverage, and that's why we encourage people to check with their insurance company first.
So, for example, that ccfreevax.org, a Kaiser member should not use that because they should use their own Kaiser app to schedule that vaccine. Is what
They
you're saying?
should, yes.
Okay. Sure.
Oh, sorry.
If they can't get an appointment at Kaiser, what are they supposed to do?
I think.
And realistically, we can't keep telling people to go to their providers if their providers aren't delivering. This is the never-ending chasing our tail that we've had for 3 years, which is why we need to get the providers to either step up and deliver or accept the fact that somebody else is going to deliver for them. Am I missing something here? Excuse me, Let me ask one more question before I turn the microphone back over, Supervisor Lee, and thank you for your forbearance. There are 1,900,000 plus people here in Santa Clara County. If they show up and make an appointment and get a slot in our Santa Clara County system, will we give them the vaccine?
We will provide them the vaccine.
Will we charge them for it?
We will bill their insurance company, and we will aggressively ensure that that patient is not inconvenienced. To your point, Supervisor, I think one of the things that we're working really hard to do is to really push Kaiser indirectly. And what I mean by that, if we're receiving a large number of individuals accessing vaccines at our locations, we are going to expect Kaiser to pay the health system in the county back for that service. They're obligated to do so. And we're not going to let Kaiser off the hook on that. We're going to do everything possible not to put the patient in the middle as a health system.
Does that mean that if Kaiser says we're not paying, that we're going to go after the patient?
Before we go after the patient, we are going to go after Kaiser.
But if Kaiser says we're not paying, does that mean we're going to go after the patient?
Let me just answer in this way.
And Ms. Lorenz, I don't mean to keep pounding on you. You're the one who was kind enough to lean in, so I appreciate that, and I want to say that. But, we can't keep dancing around these issues, and Supervisor Lee's done a marvelous job of teasing them out, but now it's time to sort of say, so what happens?
Yeah,
Please.
Chairperson Simonian, I think that would be something that our office could look at and advise in an off-agenda memo on. I think that there is some complexity towards not seeking reimbursement that would need to kind of be analyzed, but what your point is well taken from a policy perspective, but we need to look at that from the legal angles about when we cannot seek reimbursement and how we can do that.
Thank you. I think Supervisor Lee and I together would like to ask for that off-agenda analysis. I'm going to turn it back to Supervisor Lee and apologize for interrupting his train of thought and say thank you for letting me go. But I have some more thoughts on this, which I'm guessing won't surprise any of you. Thank you.
Sure. So after we verified an individual that's not insured and that they are not eligible for the free vaccine because let's say they make too much money, at that point, how much do we actually charge them on the spot?
Supervisor, I'll get you the exact fee that we charge for individuals that are self-pay.
Okay, so, but we do charge them something like $20 or something around that, right?
There is a fee that we're required to have as part of our schedule.
Right.
We're required by law to have that. And again, I would just stress to the community that we will work with the patient to ensure that they get the vaccine and charge those that are accountable relative to the services that they're obligated to provide for that patient. And I think, as been noted, we will work with counsel in those situations where we do not have a payer that's willing to step forward.
I mean, I'm just seeing this as an additional barrier. I mean, distributing vaccines is hard enough. We're not getting enough of it. Scheduling has not been easy, as we all know, right, for the different technological issues and whatnot. And this fee issue is going to be another barrier that we'll have to overcome. I just ask these questions just to make sure that we are trying to think at least a step ahead, because obviously we'll be facing it system-wide with 2 million people in our county. And if there's a way we could, contact Kaiser ahead of time to try to get these issues resolved so that we don't have denial of payments and whatnot. So I hope the dialogue is happening at your level to try to get these issues resolved ahead of time. I think that would be very helpful, so that the individuals are not going to be able to figure out, oh, wait, I cannot go here, I cannot go there. I mean, like you mentioned, there's a bridge access program for adults, and then there's a vaccine for children program. And all this is even somewhat confusing to us up here on the dais. I think is absolutely not intelligible for most folks. I mean, they're used to getting free vaccines. They show up to get it. Like, what do you mean I have to pay? Or why my kids can't get it? So I just want to make sure that if there's anything that we could work out ahead of time among the systems that we have at your level, I think it would be way better than trying to resolve it and sending them bills and them rejecting us, and et cetera, et cetera. Thank you.
Point well taken.
Yeah, okay. I was also told that for some of the uninsured county residents, they could go to Bascom Avenue location to get the vaccine. Do you know what that's about? Or it's just one of many?
One of the service locations is on Bascom at the main campus at
Of
the Valley
VMC.
Specialty Center Pharmacy.
Right.
That is one of the locations in which we offer COVID vaccine for all age groups.
For all age groups?
Yes.
Including the peds
Yes,
that we're talking
including
about. Great, thank you.
Pediatrics, adolescents, and adults.
Great. We had this MOVAX van previously to give out the vaccines. Are we going to use the MOVAX van this time around for this monovalent vaccine? Have we started using it yet?
Yes, absolutely, we have. The mobile vaccine program that we had during the height of the pandemic involved hundreds of disaster service workers and contractors. The remnant of that, in addition to the van itself, which we've certainly got up and running, and the pharmacy infrastructure to support supply, is a very, very small team of pharmacists and support staff. But we are doing up to 2 or 3 clinics a week focused on homeless encampments and other places that may be most easily accessible by folks who do not have insurance, such as places where day workers may be concentrated and able to access our services.
Okay, great, thank you. So I think that's certainly very helpful to get it out there for people to sign up. Well, I guess they won't be signing up. They will basically see the van, walk up, and basically try to get the vaccine on the spot, right?
That's right. We do work very closely with community groups and leaders to help make sure where we can get the word out about exactly where we will be and when is something that we do so we don't surprise folks and so they can come to us in advance when possible.
Great. So I went back and found my vaccine cards. I haven't seen them for a while. I got 2 of them because I got so many shots already. I was seeing a poster that says, "Oh, bring your vaccine card to get your monovalent shot." I would imagine that at least half the people probably couldn't find them anymore. Is that really necessary to get a vaccine these days to show your cards?
For most people, it is not at all necessary to have your card, so do not let that hold you up from going to get your booster when you get an appointment. For everyone ages 6 and up, the recommendation is a single updated COVID booster, regardless of your immune status, regardless of your I don't know, which vaccines you had or didn't have previously. The only situation in which there's some more nuance is for young children, 5 and under, depending on what their original series was. And in those settings, there may be some nuance about how many additional shots are needed. However, even for parents of young children who don't have those original cards, there are ways for both your vaccine provider and for you to look up that vaccine history without having the card itself, and your healthcare provider can help with that.
Great. And so in this case, there's not 2 times, it's a one and done deal, right?
It is for this season, one and done.
Wonderful. Last question. I promise it'll be last one, Chair. Flu vaccines. We're getting them out there now at the same time. This is September, October, greatest time to get that vaccinated right now, and I know that's very much available. There has been no issue regarding getting both the flu vaccine and COVID at the same time, correct?
That's right. The current recommendations are that it's absolutely safe and effective to get your flu shot and COVID shot at the same time. Given all the reasons we've just discussed, logistically, there may be some places that have their COVID supply up and ready and not flu or vice versa. But if you've got access to both, we've certainly encouraged people to get both at the same time.
Very good. Thank you very much, Dr. Roman. Thank you, Paul.
Dr. Redmond, let me ask what I hope is a simple question. We'll find out. Some of us got Moderna, some of us got Pfizer. When it comes to the new booster, does it matter what we get and what we've gotten previously?
It does not matter, neither what you had previously or in terms of the safety effectiveness of both options. Take what you can get, whether that be Moderna or Pfizer.
All right. Now, I know you just answered this question. We're going to ask it again just to make sure I got it absolutely straight. So if I have had nothing but Moderna, and the only thing available to me now is Pfizer, it's absolutely okay to go get the Pfizer.
Absolutely okay, effective, safe, and my recommendation.
And if I've had nothing but Pfizer up till now, and the only thing available to me is Moderna, it's absolutely okay to go get the Moderna.
That's correct.
All right, clear as can be. Thank you. It's good that something is clear in this whole conversation. The next thing I'll say is I want to underscore the point that Supervisor Lee made because it's what has been running through my head since the conversation began, and that is if with all of the talent we have at this dais and the top leadership of the county's health team here and the 2 members of the Health and Hospital Committee, if it's this complicated, I can't even begin to imagine what a member of the public is feeling as they confront this set of challenges, ambiguities, uncertainties, inconsistencies. So let me just ask you, Dr. Rudman, whose fault is that? Is that the federal government's fault? Is it the state government's fault? Do we bear some responsibility for that? Does the responsibility rest with the private sector? Is it the fault of providers? Or is there so much fault to go around in so many different places that we can't really hold anybody accountable, which is part of what I'm starting to sense? What would you say? I know you're a healer and a public health leader, but at some point we have to ask ourselves who's accountable for what if we're going to fix any of this.
Well, before I defer to Ms. Hanson, who I see is leaning in as well, I will say wherever the fault lies, this is not a new problem. What we have seen is a return to the system we all lived comfortably or very uncomfortably under 4 years ago, and had a brief period where that wasn't the case. And so I think it's been a mission of the Public Health Department for a long time to help identify where there are gaps in helping people access the care they need and seeing how we fill those versus highlight them and push others to fill them. And that's what we continue to do here, is help bring people the information they need to navigate a very confusing system. What would you add?
Ms. Hanson?
I would only add that I completely agree with your comment that the current state of play is incredibly difficult to navigate, even just from a basic information about what to do standpoint, given the variety of sources of information, well-meaning as they may be, providing guidance on how best to approach vaccination, approach COVID prevention. That I think there is mass confusion. And then to the prior conversation about how hard it is to access vaccination, depending on what system you belong to, who your insurance carrier is, continues to just be profoundly disappointing. One thing I would say from my role that I just continue to be profoundly gratified by is that as other systems seem to lean back in the face of new challenges, new vaccine releases, a pivot towards the more traditional payment structure for vaccination, that our system continues to try and lean forward, and that's both the Public Health Department and our health system to try and fill gaps, make it easy for people, give folks who may otherwise go without access to vaccination a path to be vaccinated. And it continues to be, frankly, extremely vexing that some of our other healthcare providers who should be natural partners, who get even greater resources than we do from insurance carriers to deliver that care, keep not building it, buying it, or otherwise figuring out how to deliver it when we, as a public system, continue to lean forward and do so and actually treat the patients that they're getting revenue to treat ourselves.
I'll just say I think this phrase "extremely vexing" may be the understatement of the day, and I applaud your tact, but I think I would say that the time for tact is over. Look, we all have our own views about the state of healthcare in America today, and different folks have different points of view, fair enough. But you know what? If Mr. Rao can't get her broken arm fixed, that's probably just a problem for Mr. Rao. If Mr. Rao can't get her vaccine, then she's putting the rest of the community at risk. We have been exhorting people, pounding on them, and requiring them, in some instances, to get the vaccine. And now we are doing all that in a system where getting the vaccine is, in many instances, difficult. In some instances, may not be possible as a practical matter. And in other instances, is going to be on the financial capacity of the folks who we're exhorting to get the vaccine. Am I misstating the facts here? All right, then let me ask a very direct question here, and Ms. Hanson, I'll turn to you because you're the Chief Operating Officer. You know, I was frustrated, and I know you remember this. Dr. Rodman, I don't recall how close you were or weren't to this part of the conversation. I was frustrated during the heart of the pandemic when people seemed reluctant to press on some of those healthcare providers, whether they were the Kaisers or the Sutter/Palo Alto Medical Foundations of the world, when they were slow to step up. That's my characterization, and I stand by it. Here we are again. I don't think we have months and months and months. You know, I keep looking at those stubbornly high sewer shed numbers. I read the reports that indicate that this is a particular concern to people of a certain age. And so I'm wondering, what legal tools, if any, do we have to compel these folks? And if not legal tools, what tools do we have to hold folks publicly accountable for their failure to deliver? I'm trying to choose my words carefully now. Thoughts?
Well, I have thoughts. I will say, I think as a county, we've tried to do our darndest, one, to first deliver the care that was needed for the community, while also trying to push very hard on our partners to step forward. I think what Mr. Lorenz mentioned earlier, which is going ahead and delivering the care and then billing some of those other systems for the care that we're delivering when they should have stepped in, does create an incentive for them to step forward and deliver the care. I know that for Kaiser in particular, they are loath to have anyone else provide the care because of the way that they're structured. That said, I've been surprised that that hasn't been as strong a motivator as I think some of us expected it might be, and at the slowness with which some of these systems have just not solved some of these problems or chosen not to solve these problems. I do think that a lot of the regulatory authority to hold systems accountable exists at the state and federal level, and some of it is beyond some of the best claims or enforcement mechanisms that may apply are not ones that we are in a position to leverage. But I would also defer to council on whether there's additional strategies or additional advocacy that we may be interested in pursuing, including with those actors who may be in a better position than we to try and enforce some of the requirements around delivery of care that we may not be in a position to assert.
I'm going to ask for an off-agenda memo from our county counsel's office on the legal tools and/or remedies we might have available to us as a county to compel greater compliance, greater participation, whatever the proper term of art is. And I'd like to ask if that's possible to get that in the next 2 weeks.
Yeah, I will look into that.
Thank you. I'd also like to ask, can we agendize this item appropriately for closed session as a potential litigation matter for the first meeting in November?
So that I don't know off the top of my head, but I'll look into that.
Let's pause for a minute and figure it out then. Ms. Hanson, as an alum of the county counsel's office and now our chief operating officer, that agenda gets set how?
That agenda is set, if there's an item that can be properly brought forward to the board as a closed session item, the county counsel's office would agendize that item for closed session.
All right. I am hereby formally requesting as one member of the board that that item be agendized at our first meeting in November. Supervisor Lee will be a judge of whether he'd like to lean in and say, me too. Supervisor Lee, don't want to put you on the spot, but if I can, I will.
Yes.
Thank you. I heard so now you have two members of the board who are not able to compel, because we understand it takes three, but you got two members of the board who'd like to discuss the litigation tools, if any, available. And the reason that litigation is reasonably considered in such an environment, in my view, is that in the absence of a robust participation, we are forced to look at litigation tools as a way to compel if necessary. And, you know, we spent more than a year dialoguing and interfacing and conversationalizing this set of issues during the height of the pandemic. I don't think we can afford to do that again. And while the immediate concern may be lesser, it's not lesser for anyone who loses a loved one by virtue of their practicable inability to access this system. So I will make that request of Mr. Williams as well, understanding he is no longer county counsel, within the next few business days. I will make that request of Mr. Lopresti, who is our county counsel, within the next few days, and I will ask that the item be agendized. And then, looking to my own staff, sometime in the middle of November loosely defined, I'm going to ask Supervisor Lee if he will join me in conducting a special hearing on the accessibility and availability of the vaccine. And we'll have it right here in these chambers at a time that works for the committee. And we will invite representatives of these organizations to come and respond to these questions. If they choose not to participate, so be it. But I would gently remind everyone that the Board of Supervisors as a body does have subpoena power. And if it sounds like, you know, this is an overreach, it's because we can't seem to get folks to step up. Now, if a month from now, the system has sorted itself out, no one will be more delighted. But if it has not, then the time will long since have come and passed, in my view, to say, what do we have to do to make it work? And Mr. Lorenz and Dr. Rudman, that may mean we just have to say, our, quote, healthcare partners are failing us, and we have to step up as the only public health agency that exists for close to 2 million Santa Clara County residents. And if that's what it is, that's what it is. And, you know, I don't want to name, blame, or shame unnecessarily or inappropriately here, but, you know, if folks are saying we want people to come to us and we're not prepared to reimburse if they get their shot somewhere else, then they have to stand and deliver. Just that simple, okay? So, Dr. Rudman, my next question, which is related to all of that, is, looks like COVID's going to be with us for a while. We're going to need to be taking boosters, at least that'll be the recommended action for not just weeks or months, but potentially for years to come, yes?
I think it's too early to know what future years may look like, but the most recent indications from the FDA suggest that we do continue to anticipate updated vaccines available annually, and their usual practice is to evaluate what best we know about the current level of threat compared to the efficacy of those vaccines. It is very possible that ongoing annual boosters will be the recommendation for a number of years.
And my point here, and thank you for that, my point here is that if ongoing annual boosters are likely to be recommended, we better figure this out, because we can't have this conversation once a year and sit here and wring our hands and say, gee, the system is cumbersome and doesn't work terribly well. Because if we're serious about equity lens, then truth be told, folks who are prosperous, folks who are privileged will find a way to get what they need. Folks who are not will not. And then it seems to me we've got a highlighted, underscored obligation to make sure that we stop having this conversation and start delivering it. I'll talk with my staff about scheduling a meeting once this meeting is over. Anything else on COVID-19? Dr. Rudman, anyone else? Supervisor
Yes.
Lee?
I just wanted to actually say thank you to Paul for helping us in terms of obtaining the COVID vaccine for this upcoming Day on the Bay, this coming Saturday in Alviso. And so I want to get the word out to folks to attend. It's going to be in Alviso Marina Park from 10 to 3. And free pumpkins and whatnot, but also COVID vaccines and also flu vaccines as well. So I just want to get the word out to folks. And thank you, Paul, for the extra effort to make it happen. Appreciate it. And you and your staff, the team is amazing. Will the MOVAX van be out there too this time, you think?
Public health will be out there supporting in a number of ways as well.
Great. Thank you, Dr. Redmond. Appreciate it. Thank you.
I believe, Supervisor Lee, that I can look to you for a motion to receive the
Yes, so
report.
moved.
I'll second that. I'll confirm with the clerk we have no other speakers,
There are no requests to speak.
and we'll ask you to call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Smidian.
Aye.
Motion carries.
All right, that takes us to, I believe it is item number 5, fentanyl report. Who's presenting on this one?
Yes, good afternoon, Chair Simidian and Supervisor Lee. Sherry Terrell, Director with our Behavioral Health Services Department. You have our written report, and Eric Riera, our Deputy Director, is here to provide some brief updates, and we can answer any questions you may have. Thank you.
Thank you. I think what I'd like to do is go for the brief update, and then before we weigh in with comments or questions, we'll go to members of the public, if any, who would like to speak. Thank you and welcome.
Thank you. Eric Riera. I'm Deputy Director for Behavioral Health, and I oversee our service delivery system. I'm here as part of our submission on the report to updates to fentanyl use and overdoses in Santa Clara County. Just a few brief comments, and I'm happy to answer any questions about our report. We did start off our report with requested information relating to fentanyl-related deaths in Santa Clara County. And as noted in the report, we've seen significant rises in deaths starting between 2019 and 2020, from 27 deaths in 2019 to 161 deaths in 2022. And we're trending this year for similar levels in 2023. This mirrors a lot of what we're seeing on a national level when we saw dramatic rises in deaths beginning actually in 2013 nationally. And it's a very complex issue, as we all understand, relating to reductions in prescribed opioids and the increased presence of illegal fentanyl in the drug market. Our report outlines efforts in three focused areas. First being around prevention efforts, second, harm reduction strategies, and third, treatment and recovery. On November 7th, we are presenting a much broader substance use work plan to the Board of Supervisors to summarize on a broader scale work that's being done to continue building and expanding substance use services and strategies in the county with our work across multiple departments. And with that, I'm happy to answer any questions that you may have related to the report.
Thank you so much, and it's Mr. Rivera, yes?
Mr. Riera, yes.
Spell for me, please.
Riera.
Riera, forgive me.
Correct, no problem.
With a name like Simidian, I try to get other people's names right if I can. We do have one card that I'm aware of, looking to the clerk. Mr. Soto, please come forward, and you have up to 2 minutes if you'd like, sir.
Paul Soto from the Horseshoe. First of all, I'd like to say thank you for your advocacy. I was very, very impressed by what you had just stated right now with respect to the last item, and I appreciate that. The deficits that were created by the three strikes you're outlaw, we're kind of like experiencing that result. It's one generation later. And the deficits that were created in the residential treatment, THU systems, outpatient systems, we are now beginning to experience in the same way that racial inequities were highlighted during COVID. We are now seeing those deficits, those kinds of deficits being surfacing within the context of those three areas. So I'm also very impressed by what Supervisor Lee has been able to accomplish in a short period of time, acknowledging those deficits. And he's been very successful in that. Now, how do we scale that? And the reason why I'm concerned about that is because if I want treatment, I can't access it. I just experienced that a couple of months ago. I wanted treatment bad. I mean, I was suffering. I was dying on the streets. And there was an email sent directly to Mr. Lorenz. So I know that he was aware of that. He was aware of my condition, exactly what was happening. I was literally dying. I was sleeping in doorways. I mean, I was just completely destitute in every single area, physically, spiritually, emotionally, and mentally. And I could not access health care. I couldn't do it. But if I had a broken arm, I'd get an ambulance ride straight to Valley Med, and it would get treated immediately. So there's a constitutional violation there in terms of equal protection under the law. We don't have equal protection under the law when we don't have equal access to health care. And you highlighted that when you stated that people that have resources in affluent areas can access health care or figure out how to do it, whereas people in the barrios cannot. So thank you.
Supervisor Lee, questions, comments?
Yes, first of all, thank you very much for the report, Mr. Riera and your staff, on these, unfortunately, not a good statistics, right? Fentanyl death data that's shown in the chart is alarming. Some of deaths is rising sharply since 2020, and a few doubling year after year. We are currently on pace to have a similar number of deaths in 2023 for sure, and looks like you might 2022 and 23, and we would look like we'll set a record at this rate. So it seems to me that what we are doing has not really slowed down the increasing deaths. But of course, what we've been doing, if we didn't do it, it would probably be much worse than what we're seeing. So I just want to say that this is not so much a criticism to our county, of our administration, but this is also a trend that we are seeing nationally as well. As we try collectively as a county to address these steep increases on the deaths of fentanyl, there's a need clearly to improve education, prevention outreach for everybody, especially for the youths and the young adults as well. My office has reviewed the Fent facts on the BHSD website. It's certainly very highly informative and useful for those who get to go to the website. But as we know, 99.9% of people, especially those using fentanyl, will not likely be able to access that website. Not that they don't have the access, they just don't know even it's there, right? Interesting enough, it turns out that the messaging of fentanyl being a killer opioid, fentanyl takes friends, opioids, you take them, they take you. It sounds good, but from the reality, it seems like it comes from a space that's lack of understanding for the people who are either already addicted to opioids or those who have already made the decision to experiment with the drugs to stop them. So it really doesn't provide opportunities for the constructive conversation that is necessary. Like, for example, the folks leading the Song for Charlie has actually advised us against those type of messaging, as I learned during a fentanyl town hall earlier with Senator Becker. They said that the messaging that opioids, fentanyl are bad for you, may kill you, actually does not really work. Instead, the messaging around hope and undoing damage to our bodies physically and mentally seems to work better. So that's something that we've heard. I'm no expert, I'm just the messenger here. So I just want to share that with you to look into it to see if that would be necessary, that we could change our messaging or add these new messaging to reach a different audience, for example, for prevention. Does that make sense?
Yes, and I appreciate your comment very much. I think, in my experience, sometimes we have to have multiple different types of messages to reach different people in different ways. And certainly our initial work with Songs for Charlie has proven very enlightening. And we're learning a lot from that work. And I expect that we'll see some new types of messaging going out as a result of that partnership. But again, and I don't have to say this here, it's a complex issue, and part of our challenge is to figure out what type of messaging is going to work for the clients and community members that we're trying to reach, and which ones we're not reaching based on the messages that we have, and how can we develop new engagement strategies to help connect them with services. So I appreciate your suggestion.
Yes, and I think you hit it to the point where different individuals require different messaging, and especially the young people and youths. I can tell you right now, I have teenage daughters, and their modes of communication and the words they use is something that I am still learning every day. So I think to further study better practices for the outreach to our youth and young adults, I would like to ask your staff and the Prevention Services Division at the BHSD to work with our youth task force, led by the Office of Children and Families Policy, and also our youth advisory group, say at Alcove in Palo Alto, to really understand and learn ways that how our youth would think would be the best practices for this type of outreach on substance abuse to our high school kids and our young adults. Would that be possible?
Yes, absolutely.
Okay. And I would like to ask the administration to also explore options for increasing the fentanyl test strips distribution more widely across our county, just like we are doing right now for the Narcan kits as well. Yes?
Yes.
Okay. Well, our county, I think, has been the leader on getting our Narcan kits to our community earlier. However, by the time people use Narcans, it really is already too late. We need to promote things like fentanyl test strips for people to use before overdosing on drugs to save lives and finding ways to reduce the demands of this very dangerous poison. So one of the area I would like to ask is, how about VHHP? Is there something that VHHP can do more in this regard?
We have a very active partnership with VHHP for both the distribution of the fentanyl test strips as well as the Narcan kits and training.
Great. And then as far as the use of Narcan kits, we are getting distributed. Do we track how many times these kits are being used at all?
We do not track the actual use of the kits, no.
No, okay.
Not that I'm aware of.
So I guess I'm concerned about the follow-up, right? The fact that they actually used Narcan, to me, mean that somebody got overdosed and somebody just survived from an overdose. They almost died, right? So after surviving death, is there a way that we could get the information out to these individuals that they could be enrolling to some type of a program so that they could be better educated, or maybe even a medical detox type program?
Yes, that's part of the strategies that we're looking at in terms of, when we do have an encounter with someone in the community and Narcan has been administered, how we can, again, get the messaging out to them about how to seek and access services. It can be a challenging situation sometimes. People don't want help at that point in time, but we're also looking at how to engage people around them as a different type of engagement strategy. So if they're family members or friends or other folks that they're spending time with and that person isn't willing to engage, how can we help support people around them as a support system to help connect them with services too? So we're trying to evolve our engagement strategies as we learn more and we connect with more people out there in the community and learn more about the challenges that they're facing in terms of their readiness to engage in services. So I expect to see those strategies change over time as we learn more about this crisis that we're dealing with.
So let's say on the example, let's walk this through in terms of processes. Let's say an individual just went through an episode of overdose and was saved by Narcan, or the family members, after that fact, wants to sign up to enter into some type of a such program. Who do they call?
Well, we hope it's pretty easy in that they just call our central access line, and they get a screening over the phone, and then we help make that connection for them. We're also exploring some additional changes in terms of how people access services to make it easier. If they, for example, have familiarity with a local substance use provider in the community, that we're going to make it easy for them just to do a direct connection so that they don't have to call us. They can go directly to those providers in the community and access services directly. And then that provider will work with the county to get them enrolled in our system of care.
So for mental health issue, we have 988, right?
Yes.
What's the number for this? Do we have something easy to remember like that, or is it more like
They
a
can certainly
10-digit
call
number?
988 as well, but we have a 1-800 number that folks can call to access services.
So I just make sure that number is widely available. What is what is the number?
I'll have to look it up. I'm not having it off the
I
top
could
of my
share
head
it.
right now.
Eric, it's 800-704-0900.
All right, let me repeat. 800-704-0900.
Correct.
Okay, thank you very much. I think that's helpful to get the word out. And then the other thing is, on the report, it talks about we are now moving toward increasing another 48 slots for youth substance use treatment there. And there's something that will happen soon. When would those become available?
Are these the residential slots?
It seems like that's what they're talking about, 48 slots per year. Looks like it's residential they're talking about. So,
Yeah, we have a combination of strategies. So we're expanding youth residential through a contract with the camp. And we're also expanding our outpatient services through the school system and our various providers in the community. And we're working on that right now.
okay. And then the phone number we just gave, the 704-0900 number, that's for both adults and youths, right? There's no different number
Yes,
for the
that's
kids.
correct.
Okay, very good. And I just really want to highlight that these number of deaths in fentanyl is one of the reasons why I've been talking about some type of mobile opioid treatment referral that we've been working on. Our efforts to distribute Narcan has been truly quite remarkable of how many places they have been distributed and they have been used. We have used them in jail, we've used them in schools, we have them used now, we're getting to bars and restaurants. But at the same time, I think we need to also go further than just dealing with the Narcan distribution itself to deal with either afterwards, like the after effect, or even better yet, beforehand, so that they don't need to use this. And focusing on treatment and prevention, we really need to make sure that the help of substance use detox is truly accessible and easy to find without the red tapes and hurdles that often accompanies them. So I just want to make sure that we get these more out there. And same thing for the phone numbers. If this could be on all our buses, right, on the VTA buses, or any other type of pushing on both Facebook and, according to my daughters, Facebook for old people. So maybe on Insta as well, Instagram and other areas, I think that will be very helpful. Thank you.
Thank you.
Thank you, Supervisor. Let me I've raised this issue, I think, once before. I can't remember if this was the forum or not. There does appear to be some controversy around test strips. What's that controversy about?
I'm actually not familiar with the controversy. Perhaps Dr. Rudman?
This may not be exactly what you're pointing at. I think in general, there are always sort of concerns about striking the right balance of helping folks be safe and as safe as possible while helping to get to the point of recovery and accepting the treatment that may benefit from them. And so I think in that context, test strips are some conversations about fentanyl test strips. In addition, the fentanyl test strips that the Public Health Department distributes in accordance with our harm reduction program were originally designed to test drug supply in forensic settings, but have been adopted to address or be used to test drug supply for folks who intend to take it, to help make sure they do so in as safe a way as possible. In that setting, we always warn folks, that just because the test strip is negative doesn't mean you're about to do something that isn't potentially harmful to your body. So there's both a concern that there may be a low enough amount of fentanyl in the substance that the test strip doesn't turn positive, even if it's there, or that the test strip may not show positive when there are very low levels of fentanyl or other substances that are similarly very harmful to folks. And so this is part of why the Public Health Department, anytime we are distributing fentanyl test strips, are doing so in combination with naloxone, other instructions for how to reduce likelihood of overdose, such as using with others, and then always in combination with support in accessing treatment and other services that will help folks reduce their use if they're ready to do so.
Do the test strips require that the product be crushed and placed in a liquid?
Yes.
And do people really do that?
Yes.
Okay.
We have received extensive feedback from our own harm reduction clients, from our Drug User Health Advisory Council, and from many other jurisdictions who've done sort of more formal research on these, that this is something that folks are not only willing to do, but really interested to do to help stay safe and protect their own lives and that of other folks.
And forgive my lack of terminology here, but at that point, the product is essentially dissolved, yes? Or
Yes, I think the intention for most folks, or the most common mechanism of use, is not to dissolve all of the product somebody intends to use, but a sample of it. And so that's another caveat that we provide people is, especially when we're talking about illicit substances that are manufactured outside of a controlled setting, one part of a pill might not have fentanyl and another part does, or one part of a bag of a substance might have fentanyl and the other part might not.
yeah, this has been described to me as the chocolate chip cookie dough issue, which is one part of the batter may have lots of chocolate chips and another one not, and if you just take a sample, you don't have a real clear sense, because presumably the dissolved product is no longer usable, or is it?
That's my understanding, but it may depend how the person plans to use it.
All right, I'll just indicate I think it's a complicated issue and let it go at that. Naloxone, Narcan, are we, I've asked this question before, I'm going to probably ask it at every meeting. Are we still feeling confident we not only have, but will continue to have adequate supply to meet the demand? I'm worried that at some point we'll get word that we don't have adequate supply.
Yes, we are very confident that we have sufficient supply and we have a good, reliable supply chain to continue to order more as we need it.
If we were fielding, to Supervisor Lee's questions and comments earlier, if we were fielding requests from the community and they said, well, who do I call if I want to get a training? Is it 1-800-704-0900 or is there yet a different number?
Yes, they can certainly use that number and they'll connect the person
All right.
with us.
And this next one's a little tougher, I think. It's hard to measure what doesn't happen. So, we've had this conversation, Dr. Redmond, around what I'll call conventional, traditional public health data for decades. In the STD, STI world, some of these numbers seem stubbornly high. And frankly, I'm not sure we'll ever know whether they would have been higher still, but for our good efforts, or whether what we're doing simply isn't having the impact we hoped it would. And that makes it harder then to change course and do things in a more efficacious way. So it strikes me you've got the same challenge here. We look at the numbers, and the bar graph, I think, is pretty compelling. Sometimes I look at these bar graphs and think, really there's some data there that I'm supposed to pluck out of that. In this case, sadly, I think that it's very clear. What's not clear is I look at that trend line and I think, all right, should I conclude whatever it is we're doing, it's not enough or it's not working, or should I conclude, oh my God, how bad would it be but for the efforts we're making? Any comment on that, either Dr. Redmond or Mr. Riera?
I think that the work that we've been doing over the years has made a significant impact on that trend line. I think about the size of our community and our county, and the numbers of deaths, although high, I think would be far higher without the efforts that we've already been implementing in the county. And as we continue to evolve, I'm hoping we see those numbers eventually go down. But I do truly believe that things would be a lot worse were it not for all the things that we already have in place today.
Thank you. Last question, for me at least, is we've had some conversation previously about the fact that some school districts were slower to embrace the effort than others. In some cases, it was perhaps a simple lack of awareness. In some cases, it was, in my judgment, a case of denial. And some we had conversations that were still underway and we're hoping to make some progress. Where are we in that, and any sense for what the resistance is, if there's any still out there?
I think we are making progress. Last time we had updated the board, we had 6 school districts that were expressing some hesitancy about training, and since then 2 have signed on to get training from the county and access to kits, and the other 4 are agreeable to further discussions with us. So I do feel like we are making progress, and I'm optimistic that we'll get the majority of those 4 on board fairly soon.
And related to this, the conversation has pivoted a little bit to bars and restaurants. Thoughts about how that outreach might work?
We have not yet begun that outreach and engagement with the bars and restaurants, but we're still working on how to tailor that messaging to them. But I think if we can find some champions out there in the community and get them on board and show that this is actually an effective way to distribute naloxone and Narcan out there in the community in a way that's not going to negatively impact the business, I think that we'll be able to build up momentum over time.
Yeah, let me just offer, each one of our 5 districts obviously is very different. By definition, we have different geography. My district has 9 of the 15 cities and towns in our county, 8 of them wholly contained in the district. Many of them are smaller communities with robust downtown bar and restaurant scenes. They operate through a local chamber of commerce in many cases. And so it's, unfortunately for your effort, there is a lack of economy of scale because you got to go to this chamber and that chamber and this chamber and that chamber because folks are sort of hyper-local about their business affinity. But if we can help put you in touch with folks there, arrange for trainings, we're happy to do that in our office. We have working relationships and sometimes have partnered with folks in this organization or that organization. It's both a struggle and an opportunity, frankly, because these organizations are there. But they are, as I say, more hyper-local than in some other settings in the larger communities. So we look forward to working with you on that. All right. Supervisor Lee, can I get the formal motion to receive the report?
Yes, so moved.
And I will second.
I do have a couple of follow-up questions, if I may.
Oh, please. Thank you. Go right ahead.
So we talk about the Narcan being distributed through these vending machines as well, and I learned that these machines each hold about 150 kits.
That's correct.
Yeah, even though we call it vending machines, actually we do not charge a fee, right? These are free.
That's correct.
Freely available. Okay, good. On that note, for all the Narcan kits that we distribute, do we provide the phone number that we just talked about for people who would like to seek help? That number is right there on the box, or so that people would be able to access that easily.
That I'm not sure. I'll have to check on that.
So if possible, I would love to get a sticker of that phone number and make it
Yeah.
as big as possible so people know this is the number to call.
Yeah, we're actually working right now on a sticker to put on the kits to access a quick online training. So I'll definitely bring that back to the
Great.
team.
All right, thank you very much.
You're
That's all I
welcome.
have.
Thank you. Thank you. Call a roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Motion
Motion
carries.
carries unanimously. Thank you very much. Thank you again.
Thank you.
Takes us to item number 6, report on the De Anza West Valley Clinic effort. We do have a card for Mr. Soto, who would like to speak on this item, and as soon as we get our report, I will call him up. So, Mr. Soto, that has been your preference, sir. Thank you.
Great.
Who's going to present?
Thank you, Chair Simidian. So as you well know, we did present this item before the full board. We do have very active engagement by the Community College District. At that board meeting, Supervisor, you did request that the team meet regularly with the De Anza group. That has in fact been scheduled for every other week, beginning this Friday. With that being said, I know Jeff Draper is also available, and we're happy to take any questions.
Thank you. I do have some questions and comments, but if that's the extent of the formal report, in addition to the published materials, let me call Mr. Soto up if he would like. And again, up to 2 minutes on this item.
Paul Soto from the Horseshoe. I read the report, and the issues that I take with the building of a new facility in that area is that it's inconsistent with the definition of racial equity. Now, the county is not operating on a legal definition of racial equity. It doesn't exist. You cannot point to it. What you have is a mission statement. You have a kind of hope, kind of an aspiration. It basically reads like a mission statement for a nonprofit. It's these kind of ambiguous, nebulous kind of hopes and aspiration that we hope we get there and we hope that this is the means to do it. But racial equity needs to have a legal definition to it because you're using it in your documents to legitimize a particular budget allocation. And so until we get to a point where we can actually institutionalize racial equity, things like this wouldn't happen. I mean, you have, De was a colonist. He was a colonizer. That's how he came, that's how he got here. And then once De got here, then they instituted the mission statement via the Franciscans in Junipero Serra. And then we locked in the 21 missions when Burnett made the deal with the devil, which was Father Alemani, Father Acoletti, and Father Nobili of Santa Clara University. And so, you know, and then we're going to give a new facility to De and yet there's a gentleman that came in here that said we've had leaky roofs and promised a building in East Valley Clinic for 8 years and that hasn't happened. And then in the next sentence, you're going to talk about racial equity and how in this document that racial equity is being instituted. It's a mock and it's a hypocrisy.
Mr. Draper, you're still with us, yes?
I am. We do
Thank
have
you.
one request to speak virtually as well.
Forgive me. Let's go ahead and hear from that individual.
All right, the next speaker is Ken Horowitz. You have 2 minutes to speak. The timer will start when you begin speaking.
Yes, good afternoon. This is Dr. Ken Horowitz from your Health Advisory Commission. And I see in this new health center at De Anza, there'll be a dental department, which brings me to our efforts as a Health Advisory Commission to look at some of the issues that don't get the play that they get normally, which is dental services for 450,000 Santa Clara residents, which get their benefits through Medi-Cal Dental. So this coming Health Advisory Commission meeting, which will be on November the 15th at 6:30, our Health Advisory Commission will be looking at dental services that are being provided by the county, particularly for the Medi-Cal recipients, whom many of them are under the Family Health Plan. Now, our commission has been looking at other counties, seeing what they're doing in terms of dental services. We've met with the Department of Health Care Services. We've met with the County of San Mateo. So I'm encouraging you supervisors, as well as your health policy aides, to attend our November 15th Health Advisory Commission meeting, and also members of the public through teleconferencing could also express their concerns regarding dental services within the county. Lastly, I would say that in looking at the plan, I think you need to expand the square footage of the amount of dental space available. Thank you for your time.
Let me double check myself now.
That concludes the request to speak.
Thank you very much. Mr. Draper, forgive me, I'm working my way through some of the materials. I did want to confirm that following the request at the board meeting, we've moved from monthly meetings to a more frequent set of interactions between our organization and the Foothill De Anza district. Is that correct?
Yes, Supervisor.
All
About
right.
twice monthly at least.
Okay. And Ms. Hanson, if I could talk to you about that offline for just a minute, that would be helpful. Thanks, Mr. Draper. And I was interested in seeing the list of folks on page 3 out of the 4-page report, packet page 16, that our county and our consulting architect are working with to discuss options for the project. Campus Facilities Committee, DASG, Student Government, College Council, group leaders, collect input, followed by further conversations with the Campus Facilities Committee and the Student Government and the College Council again, and then eventually, at some date to be determined, the Foothill De Anza Board of Trustees. I would just ask that these all occur as expeditiously as possible. I do know sometimes you have to go slow to go fast, but I just want to make sure we're getting to the point where we go faster without.
Supervisor, if I could take the opportunity
Please.
to tell you that the purpose of the Friday meeting, one of our agenda items is to clarify the expedition, how to go faster with this, and we'll see what we can do.
Thank you very much. I appreciate that. I certainly understand and appreciate the fact that there are a range of constituencies that need to be consulted if we're going to get the best possible project, but I also want to make sure that we do that in a timely fashion and that it doesn't cumbersome. What is the next, and forgive me, I should remember this and I just don't from our full board meeting, what's the next action that will come from our board to advance the project?
I believe that would be authorizing some funds to move forward with design once we've settled the amount of the money and considered it in our larger capital program, Supervisor.
All right, so I do notice on, again, page 3 of 4, packet page 16, it says, a status report and recommendations for next steps will be submitted to both the Foothill De Anza Board of Trustees and the County of Santa Clara Board. The administration anticipates the entire process will be finalized sometime between December 23 and January 24. Does that still strike you as a reasonable timeline to come back to us and say, here's what we need?
Yes, Supervisor, given, we're a little dependent on the list of meetings and community stuff that the district wants to go through here. So we'll verify that more likely next month than this month.
All right, I'm going to look to my office, and I see Mr. Pascal here, and we should follow up on timeline issues to see what we can do, if anything, to be helpful in making sure everybody's fully engaged, but also brisk in the effort. So the likely next request for our full board would be to come to us and say, we have a clearer notion of what it is we would like to see on the site, what makes sense for the population we hope to serve, and we now need some money to design such a structure and a facility, and that's likely to be sometime in December, January, if we can stay on schedule. Is that a fair summary, Mr. Draper?
Yes, sir.
Okay, thank you for that. Let me ask Mr. Lorenz, give Mr. Draper a break here. Looking at, I think it would be page 2 of the report, at the top of the page, there's a grid that started on the previous page that did in fact include dental, as Mr. Horowitz indicated, but then goes 2 through 9 with very rough estimates, I understand, on whatever. Family planning services. Which of these categories is that likely to be contained in? Is that number 2, the family medicine line in the grid?
Yes, Supervisor, that would include family planning, as well as, again, behavioral health services in terms of mild to moderate.
Okay. And do we ever subcontract, in essence, for those services? I'm thinking on the, I'm trying to imagine potential partnerships, and if the answer is typically not, that in our various 10, 12 clinics, depending on how we count, we provide our own services there, or I'm thinking of Planned Parenthood as a possible partner on the family planning side.
Typically, Supervisor, we provide those services within the auspices of our own practitioners in clinic.
Okay. All right, then. Supervisor Lee, I know you need no persuading since you were a co-author of this referral with me, so I'm going to say thank you for that again. And I know some folks have left, but I did want to look up and down the row and all the way around before I lose any of our team here on this issue of equity. Many of you, and certainly my board colleagues, have heard me in previous meetings on the very simple math, which is that there are 3 or 4 county hospitals or clinics in every one of the other 4 districts, but that in District 5, where the De Anza campus is located, there are 0. So while it's always important that we do our analysis and understand the needs of the community, and certainly that we take an equity lens to that work, it's pretty straightforward here that if you are a low-income person of color in District 5, and they are still there, notwithstanding the fact that we don't offer a lot of services, and notwithstanding the fact that the cost of living is high, we have people who are struggling to hang on. If you are still there, there is no place to go to get the services unless you can somehow get yourself to a location that is less familiar, less convenient, and more remote. Some folks can, some folks can't. Some folks do, some folks don't. My recollection, Mr. Lorenz, is that there are something like 40,000 Medi-Cal recipients in District 5. Am I remembering that right, if I'm not putting you on the spot?
Yes, sir, I believe that is the number.
That's not an inconsequential number of folks who might be served. And so I am hopeful that one day there will, in fact, be the North County site, which is, I think, already under construction. Mr. Draper, did we get that October 2nd permit that we were hoping for?
We actually got it on October 6th, but we're moving forward, sir.
All right. I'll take yes for an answer on that one. Thank you. And I'm hopeful that one day that site, plus a site that will take longer because it's from scratch at De Anza, will give those 40,000 Medi-Cal beneficiaries and others access to quality health care when and where they need it. And I thought it was important to sort of take stock again of why the need is there. There are real folks with real needs in significant numbers who literally do not have a county clinic to call their own anywhere in the 8+ communities that are in District 5. And in my view, that's what equity lens should compel us to talk about. I have no other questions. Supervisor Lee, anything else?
None, thank you.
Motion to receive the report?
So moved.
Motion by Lee, second by Simidian, with the exhortation, let's stay on the timeline, please, if humanly possible. Call the roll.
Vice Chairperson Lee.
Aye.
And Chairperson Simidian.
Aye.
Motion carries.
Thank you all very much. Mr. Draper, thanks for moving this along. Thanks for stepping up the meeting pace. I just think the more often we can have some back and forth, the less time will be lost while we just wait to have another get-together. That takes us to item number 7, and item number 7, of course, is the County Health Systems Report, A through G. Item A is to hear from the Chief Executive Officer of Santa Clara Valley Healthcare.
Thank you, Chair Simidian. Outside of the written report that you have before you, I'm happy to take any questions.
All right. None so far. We'll raise our hands if we have them. Public Health Officer, we've heard from you, Dr. Redmond. Anything else?
Nothing further, thank you.
Okay. Behavioral health.
Yes, good afternoon, Chair Simidian and Supervisor Lee. Nothing additional to add at this time.
Thank you. And forgive me, Dr. Redmond, you almost got away clean on that one, but I did have one item I wanted to raise with you, not for today, but for our next meeting, let's call it in November. Could we get some feedback from you and your folks about public health issues, if any, associated with the use of artificial turf? We are getting some inquiries in my office, which is partly what prompted me. We also are looking at some new and potentially expanded uses at the fairgrounds, where this may be a factor. We also have an outstanding referral for all-inclusive playgrounds. So I think just a fuller understanding I think some of it has to do with the chemicals in the product, some of it has to do with heat retention and distribution, and there, I'm sure, are other issues that are out there, and I just don't feel fully informed enough if we're going to confront these issues in some of our work. So that would be helpful. Is that something you can bring back at our next meeting in November?
I'll look into it. Yes, thank you.
Thank you. Thank you very much. All right, forgive me, Supervisor Lee. That means we can check items 7A, 7B, and 7C. Unless you have questions, nope, none. Then that takes us to 7D, where we hear from the CEO of the Valley Health Plan.
Thank you, Chair Simidian. I have nothing to add other than what's in the report and happy to answer questions.
All right, Custody Health.
Good afternoon, Chairperson Simidian and Vice Chair Lee. You do not have a written report from Custody Health this month, but I do want to share with you that we are in the planning phase for COVID, to offer the COVID booster in our jail system. We hope to have that up and running by the early part of next week. We have begun offering flu vaccination as of the beginning of October, and that will continue, and we have, I think, pretty good uptake. Throughout the summer, we did see small outbreaks in the jail system, but those, of course, were contained. Last month, we did see there were a total of 19 COVID cases on the adult side and none on the youth side. As of today, that's down to 9 in the adult side and none, again, in the youth side. I think the team is doing a good job at ensuring that we're providing testing and follow-up and offering vaccination, and we'll be happy to report those numbers again next month. Thank you.
Thank you. Supervisor Lee, all good for the moment. And then EMS, Ms. Lowther, anything else? We picked you up earlier, but I want to make sure I didn't curtail any comment you might want to make on other topics.
Nothing further from us. Thank you.
Thank you. All right. And I know if I turn to Mr. Campos and Mr. Margolin, that they'll have something that they want to share with us. So let me turn to them now and say, what do we need to know?
Good afternoon, Mr. Chair, Chair Simidian, Vice Chair Lee, David Campos, Deputy County Executive. I'm going to turn it over to Mr. Margolin, but I do want to note a couple of things. One, and there will be an off-agenda memo sent to the board on this, Governor Newsom has signed all of the 6 bills that the county has sponsored. So we've had a very successful legislative session in Sacramento. And that includes, by the way, extending the seismic retrofit requirements for VMC. And that allows the county to avoid some pretty significant penalties. So very pleased to report that. And with that, I'll turn it over to Mr. Margolin, who's going to give you an overview of some of the things that have transpired in Washington, D.C., which I know that all of us have been watching in the last few days.
Thank you, David. This will be a relatively brief report since D.C. is still frozen in place in that there's no potential for action on either budget items or bills until there is a new speaker selected. But there was progress on that front today in that the House Republican Conference met and Steve Scalise prevailed. He received 113 votes to Congressman Jordan's 99 votes. So the Republicans now have a nominee for Speaker. But Scalise does not have 217, which is currently the magic number required. If he did, they would have gone to the floor today immediately and put the votes up, but they did not go to the floor today to put the votes up. Now, why he doesn't have 217 is a matter of still of some confusion, in that you have people like Matt Gaetz, who says he's for Scalise. You have Jordan, the losing candidate, who's endorsed Steve Scalise. Yet there are at least a dozen, as much perhaps as 20 other members who, for various reasons, are not yet convinced. So what Scalise will have to do is what McCarthy had to do. He'll have to negotiate to get the votes. And of course, there are some obvious issues here. Is he going to stick with the Biden debt limit budget deal that was struck with McCarthy that took care of the 24 and 25 budgets. That's a deal that subsequently Speaker McCarthy broke and moved away from, but does the new Speaker candidate have the capacity to go back to that deal? Or does he go back to the McCarthy approach, which was to, after breaking the deal, advance appropriations bills that were at the FY 2022 level that were unsignable by the President and dead on arrival in the Senate? That's the other approach that Speaker McCarthy was forced into. So we don't know yet, except we do know that he'll be negotiating to avoid what appears to be the potential for multiple roll calls. Again, by not going to the floor today, one clear signal the Republicans are sending is they don't want to repeat the McCarthy spectacle of roll call after roll call after roll call. Now, that may change by tomorrow or the next day, but they're trying to avoid the public multiple roll calls. Another factor that may lead to a quicker than expected resolution of this issue is the war in the Middle East. There's a real urgency to having a functional House of Representatives, and this is an incredibly serious matter, and not having a speaker means action can't be taken. So the normal kind of posturing and gamesmanship that could take this thing on for days or weeks may not happen this time because of that. The Speaker also, once a Speaker is selected, is going to have to deal with an expiring CR that expires on November 16th. Speaker McCarthy, again, negotiated and passed a CR that ultimately precipitated his downfall because the Gang of Eight that ousted him used his bipartisan agreement on the CR as the rationale for why he couldn't be their candidate for Speaker any longer. So if Scalise does prevail, he's going to have, within a few weeks, the same dilemma that Speaker McCarthy has, and that the only way to get a CR done is on a bipartisan basis. There are just too many Republicans who do not want to vote for a CR to allow it to happen any other way. And a bipartisan vote led to a motion to vacate last round. So it's going to be, I should also point out that there has to be a CR because with no speaker, there are literally no negotiations going on now about the budget. There's no one to negotiate with. The staffs aren't meeting, so there's no way that the appropriations bills get resolved between now and mid-November. It has to be a CR. It's worth noting that in the existing CR, there were several health provisions extended in addition to flat funding for the federal government. And one of the provisions that was extended or dealt with was our pending dish cut. The dish cut was deferred for 6 weeks. Now, the fact that the dish cut deferral got into that highly contentious CR is pretty compelling evidence that no matter what the final deal is, we're not going to face a dish cut in the coming year, that there's strong bipartisan agreement that the dish cut needs to be deferred or eliminated, and it's almost certainly going to happen. So that completes a brief summary of where we are at the federal level. I'll make one comment on this sort of combined federal-state issue of the MCO tax that David Campos and I and others have been working on now for some time. We have a budget process on the MCO tax where the governor's going to, in his budget, put out the allocation formula in January for the first year of the tax, and we'll have a battle over several months over whether we agree or disagree with that allocation formula. But there's a second track that we've talked about. It's confusing, I know, but the second track involves an initiative that the California Medical Association, the California Hospital Association, and others are sponsoring to govern how these dollars are allocated in future years. First year will be budget negotiation purely. Second year will be also a budget negotiation, but if the initiative passes, there'll be guardrails and parameters established by the initiative. The initiative was filed on September 7th. There was 30 days after filing for the initiative to be amended, and that 30-day clock has lapsed as of last weekend. So we have the initiative as it's likely to be, and the signature gathering at some point will start after they receive title and summary. There are still ways in which the initiative gets derailed, but it's likely to move forward. And that completes my report. Happy to respond to questions.
Forgive me, Supervisor Lee.
Thank you, Ms. McGollins, for the update regarding this circus in the House. Do you see any possibility of any bipartisan deal to elect a speaker, or is it going to be hijacked by those 8 extreme right-wing members?
So there are discussions between moderate members in both caucuses about the potential for doing that, and that's gone on for weeks now. I think it's not likely, but I wouldn't say it's impossible. If the hardliners really dig in, and we have now this war in the Middle East, and we have really serious matters that need to be tended to, and if the Republican conference completely falls apart, I wouldn't rule it out. The problem is for those Republican members who choose to join the bipartisan deal, in almost every case they will buy themselves a primary challenger, and it may be a career-ending decision for many of them. So that's why it's very difficult to actually persuade them to do that deal. But you know, these are very serious and difficult times in Washington. War in Ukraine, the war in the Middle East. It's not impossible.
The number of votes are so tight, right? If Scalise adding all the Democrats is about 213, the way I counted it, assuming everybody showed up. And they would need technically 4 more votes, right?
That's if you're saying if the Democrats supported Scalise to elect.
Right, exactly. So what I'm saying is, and then if you have a few people like not showing up, those are the kind of no-show.
Right.
It doesn't count against the number. So you actually need less number to get a majority. So that's actually how McCarthy get his speakership, because he did not get 217. He actually got less than that, but by a few people basically voting present on that vote, that's how they got the number down to a small enough number just to barely squeak by to be a speaker. So I guess the question is, it is possible, but again, this is one of those soap opera to be seen in the next few days.
Well, I think it's unlikely that the Democrats will help Scalise become Speaker. He has decent relationships with Democrats, much better than Jordan does. But he is a member of the Freedom Caucus, has been historically. He's very conservative, and I think for the same reasons the Democrats, when they had the opportunity, voted against McCarthy, they'd have a hard time defending an action, even a voting present or helping to reduce the number, an action that would make Scalise Speaker. I think the bipartisan deal that you referenced is more likely to come about if a third candidate emerged or a new candidate emerged. But again, we don't have that candidate yet, and that's unlikely. Again, hard to predict what's going to happen here. I don't think Democrats will help Scalise, though. That's my guess.
Okay. And finally, it's one of those crazy ideas. You don't see Donald Trump to be next speaker, right?
I do not believe so.
Thank
There's
you.
actually a House rule that prohibits anyone who's under indictment from becoming Speaker.
Oh, darn.
So they'd have to amend that rule first. That'd be the first test vote.
Thank you.
Briefly, Mr. Margolin, just one question. It has been so long that we've been talking about the dish cut that I can't remember what the origins of the dish cut were, quite frankly. Can you refresh my memory on what was at risk and why it was at risk? And
so
obviously, the fact that it's no longer as much at risk is good news for our county, but I'm trying to get my history and context back.
Sure. So the disproportionate share hospital program has been in existence for decades, and it was created many decades ago to help systems like the Santa Clara County system that provided care disproportionately to low-income populations where the reimbursement rates were really not adequate, but the mission was very important and supported by the federal government. So these supplemental payments were approved. These dish payments were approved decades ago. In 2010, when the Affordable Care Act was being negotiated, there was a fairly challenging effort to pay for the Affordable Care Act. You have costs associated with implementing it. What can the offsets be? And the Democrats at that time said, if we end up having, if not universal coverage, at least a substantial decrease in the number of uninsured people in the country, we can afford to phase out the DISH program, which was created when we had a massive population of uninsured. So that was the deal that was struck, except, as we know, Safety net hospitals such as ours, our kind of system, still has been challenged, even with the Affordable Care Act, to sustain services, even with Medi-Cal reimbursement and people enrolled in Medi-Cal, there are shortfalls. And this board has discussed that extensively, I know, in recent weeks. So people have not wanted to see the DISH program go away, and there has been a decade-long deferral of the cut. But every couple years, we come to the cliff where it's going to be implemented and the Congress has to act, and that's what we're dealing with this year.
And do we still call them DISH hospitals?
That's still a term. If you qualify for DISH based upon being a disproportionate share hospital, and every state has its own definition.
And the term of art for the funding is the supplemental payments that we've discussed frequently, Mr. Lorenz, with you, yes?
Yes, sir.
All right. Fingers crossed. Let me check with the clerk. Do we have any speakers on item 7?
There are no requests to speak.
Last call. Motion to receive the report from Supervisor Lee.
moved.
So moved. Second by Semidian. Call the roll.
Chairperson Semidian.
Aye.
Motion carries. Thank you.
Thank you. All right, folks, that takes us to the end of our published agenda. We will be back, of course, for our next regular meeting. I believe it's Wednesday, November 15th. That's what it says on the slide. And we will also contend with the need to have a special hearing on the question of access to the COVID-19 booster. Thank you all once again. Be well.